Hello, thank you so much for joining us tonight for our Monogenic Diabetes webinar series. My name is Anastasia, and I am a research coordinator here with the Kovler Diabetes Center, and we're just going to jump right into it. So a few housekeeping items to note. Should you have any questions during this talk, please ask them in the comment section. We will try to address them during this talk. If we do not get to your questions today, you can email them to monogenicdiabetes@uchicago.edu, and someone from our team will get back with you. If you have any specific clinical questions or just questions in general regarding monogenic diabetes or treatment, we will be happy to schedule a virtual appointment with Dr. Greeley or another member of our endocrinology team. And a link to our scheduling system is below, or you could call 888-824-0200. So now I'd like to introduce Dr. Siri Greeley. So he is an internationally recognized expert on monogenic diabetes. Since 2006, he has pursued patient-oriented and outcomes-based clinical research with a focus on neonatal diabetes. Dr. Greeley designed and implemented the first national web-based registry of patients with monogenic diabetes who are more likely to have an underlying monogenic cause. Among his ongoing efforts are his role as the chair appointed by the Pediatric Endocrine Society to lead an international effort to develop consensus guidelines for diagnosis and management of congenital forms of diabetes. So, Dr. Greeley, thank you for joining us today. We're really excited to speak with you.
Great to be here.
Great. So just to jump right in, so could you please share with us your background in diabetes research and care and what led you to start the Monogenic Diabetes Registry?
Sure. I'd say my history with diabetes actually starts when my dad was diagnosed with diabetes when I was 14 years old, and he was 46 years old, which happens to be somewhere around my age now, but was somewhat unusual, of course, to develop autoimmune type 1 diabetes at that age. And I think that even way back when kind of set my mind into thinking of like, how do you know what kind of diabetes someone has when they're diagnosed?
Mm-hmm.
I did my PhD research at University of Pennsylvania on related to the autoimmune pathogenesis of type 1 and a role of the transmission of maternal antibodies to the baby, which in some way I think was a natural segue into what I do now, which is largely related to neonatal diabetes. How I actually ended up doing everything related to monogenic diabetes and neonatal diabetes was really just kind of a kismet or fate or a destiny, or however you want to put it, that I ended up in Chicago, where Graham Bell was already here and had discovered many of the MODY genes, and then Lou Phillipson, as the director of the Kovler Diabetes Center, was involved with Graham and some of the research, and we enrolled our first patient, who was Lily Jaffe, that many people know or have heard about. And I just happened to be the Pediatric Endocrinology Fellow who was on service the month that she came in, and I helped to take care of her. And based on my previous research, and as well as some research on the Chicago Childhood Diabetes Registry,
Mm-hmm.
we thought, well, heck, it makes a lot of sense to create a registry to help track all of the rare and interesting patients and families out there, so that we could try together to understand as much as we could about this rare disease.
Awesome. That's great. So you were talking about, monogenic diabetes as a whole, and we know that there's, two large umbrella terms underneath that with neonatal and then MODY. So what is neonatal diabetes, and how is it different from the MODY, or maturity onset diabetes of the young?
Right. Well, the strict definition of neonatal diabetes is actually a little bit debatable, but the basic idea is that if it's really, really, really rare for a baby to develop diabetes. And so it kind of makes sense that when that happens, that it's likely to be something really unusual and something genetic. And so it turns out that when we look at babies who are diagnosed with diabetes under 6 months of age, about 85 to 90% of those cases will indeed have an underlying cause that is genetic. And specifically, more strongly genetic than the other forms of diabetes like type 1 or type 2, which have some genetic factors involved, but are what we consider polygenic disorders. Whereas, as you mentioned, neonatal diabetes in most cases is a monogenic disorder, meaning it's due to a single mutation or variant in a single gene. And so most of those cases will occur under 6 months of age, but some of our research and some of other places as well has shown that the same forms that more often occur under 6 months of age can also occur somewhat later, usually not many close to a year, but between 6 and 12 months, it looks like maybe 5 to 10% of those cases will be monogenic, and the rest are most likely to be kind of typical autoimmune type 1 diabetes. And interestingly, some recent research has showed that even under 6 months, a small percentage of those cases probably are type 1 diabetes. And we don't yet really understand how that can happen at such a young age. But so the main distinguishing factor between neonatal diabetes and MODY is that MODY occurs later in life, usually in the teenage years or young adulthood. Probably the youngest case of the main causes of MODY is probably about 9 or 10 years old, and is often the onset we think is often associated with puberty or the development of insulin resistance and that kind of thing. The other big difference is that the MODY types of diabetes are overall a lot more common. We think they represent up to almost 1% of all diabetes. And among younger people, the percentage is up to even as much as 5%, depending where you set that cutoff. Whereas neonatal forms of diabetes are really quite rare. They occur in about 1 in 100,000 births, and are about like somewhere between 0.1 and 1% of all children with diabetes as a prevalence. So it's a small fraction of people with diabetes who, if you ask them, will have had it as a baby.
Gotcha. Okay. Yes, it does. So you're saying that it's very rare to have neonatal diabetes. So in this amazing registry that you all have created, what do the numbers look like for people that have neonatal forms, known neonatal forms enrolled in the registry?
Right. So from the get-go with the registry, because the research at that time was still very young, although some groups were saying that they thought these would only occur under 6 months, we decided to be a little more permissive on who could join the registry, because we knew it was pretty rare for anyone to have diabetes under a year of age. And so we kind of automatically took anyone who was diagnosed around a year of age or younger. And we have several hundreds of those cases, but as I mentioned, the majority after 6 months will not have a monogenic form. But taken as a whole group, we have over 300 individuals who have been diagnosed with known forms of neonatal diabetes. And most of those were diagnosed under 6 months of age.
Okay, great. And so out of those forms, which ones are the most common, and how are they typically diagnosed?
Right. Well, to take I guess I'll take the first question first, which is the different forms.
Mm-hmm.
Um, the most common amongst the monogenic forms are the same type that Lily Jaffe has, and many others like her, which are related to the ATP sensitive potassium channel in the beta cells.
Mm-hmm.
And unfortunately, when we start talking about gene names, we kind of run into this alphabet soup of scientific terms that can be somewhat confusing. But the gene names are KCNJ11 and ABCC8, which are the, like the DNA part. And they make proteins where the proteins have, of course, their own names, like KIR 6.2, some people might have heard of, and SUR1, or the sulfonylurea receptor 1. And those two proteins combine in a complicated, what we call heterooctameric complex, if people want a cool term to share at cocktail parties, that makes that ATP sensitive potassium channel. So those account for about 40% of babies diagnosed with diabetes. And so in our registry, we have well over 150 individuals who have those types.
Mm-hmm.
And those are the ones that the claim to fame, or the thing that people hear about them, is that they about 95% of those people their diabetes will respond to the treatment with the oral sulfonylurea drugs. And so most people, once we figure out that they have that, can be treated with those pills instead of insulin. However, they do have to take quite a few pills, and that isn't necessarily such an easy thing either. But it is nice not to have to do the insulin injections.
Mm-hmm.
The other thing I really do need to mention about those forms is that these channels are also expressed widely in the brain. And so individuals with those types have a pretty high chance of having at least some neurodevelopmental dysfunction, uh, where some cases the dysfunction can be pretty severe. They can have global developmental delay that's pretty apparent early on, whereas others, the effects might be very subtle and essentially within the kind of dysfunction that many of us might have in things like ADHD or school trouble, that kind of thing,
Mm-hmm.
where we do think it is probably related to the mutations. So that's kind of the biggest group.
Yep.
Probably the two other groups to mention that are sizable in terms of the percent of cases are transient neonatal diabetes due to the chromosomal 6q24 locus, which gets a little complicated how that occurs, but those babies tend to be diagnosed at the very youngest ages,
Mm-hmm.
but then their diabetes actually goes away within usually a few months or up to about a year, only to return, we think, in most cases, although we don't know the exact percentage. And when it comes back, it will look a lot like the MODY type of diabetes that we talked about, where it will usually come back around adolescence or young adulthood.
Mm-hmm.
And if you know, the importance of knowing your genetic diagnosis is that, especially at that relapse time, we have good evidence that they will respond to other medications again rather than just insulin. So it's really important to have that genetic diagnosis. Now, the remainder of cases are pretty much all going to need to be treated with insulin. And the one that is most prominent is actually mutations in the insulin gene itself, which we actually discovered here at the University of Chicago very early on in 2007 because of a large family we had here, who I still help to take care of. It's important to know the genetic diagnosis in those cases as well, even though they look, or their disease is a lot like type 1 diabetes in terms of how we manage it. There are really important considerations about genetic risk in the family. And also, as we go forward with different types of research and therapeutic interventions and prevention of diabetes and that kind of thing, it would be really important to know that you don't just have autoimmune diabetes, but you have a genetic cause. And there are several other types that we don't really have time to get to, things like more severe autoimmune dysfunction that can affect other organs like FOXP3 and GATA6 and PDX1, which can cause you to not have a pancreas or to have very little pancreas and sometimes have cardiac defects and other kinds of dysfunction. And typically, if it involves other organ systems, it can be a really big challenge to manage those cases with the several problems that they can have. But many of those cases too, we have in our registry who are now even adults and are managing their disease amazingly well, despite the challenges.
Right. Yeah. It's great to hear. And so I'm not sure if you covered exactly how they were diagnosed. So could you talk a little bit
Wow. So you were
genetic?
actually paying attention. You caught that I didn't answer that. I actually think that would be best answered when we talk about newborn screening.
Okay.
Because that's actually the whole point of the newborn screening in a way.
Yeah.
So we do have a question about that coming up?
Yes, we do. And actually, we can jump right to that because you actually answered the next one. So can you share with us more about your ongoing newborn screening project and how we are doing that testing and determining treatment after getting those?
Yeah. So as I alluded to, the reason to think about newborn screening for neonatal forms of diabetes, or what we sometimes call congenital diabetes, is that it's really, really hard to diagnose a baby with diabetes. And as a pediatrician myself, and thinking back when I was like a pediatrics resident, my first month working in the emergency room, it's not uncommon at all to have families come in with their newborn baby who might be a few days or a few weeks old and say, "Doc, we're really worried about our baby. He or she is not acting right, really fussy or whatever." And that's a pretty common thing for babies to maybe be fussy, colic or whatnot. And so there's a tendency to reassure. And the two big questions we ask in pediatrics in that situation are, is the baby feeding okay, like drinking their formula or breast milk? And a parent of a baby with neonatal diabetes will say, oh yeah, they're drinking really well. They're feeding, they're taking their food really, really well. And the second question is, are they making wet diapers? And they'll be like, oh yeah, they're making tons of wet diapers. And those are reassuring to a pediatrician when in fact those are what we consider like the cardinal signs of diabetes that people are probably, especially in this group, the people out there listening, are very familiar with diabetes. And the main sign of any kind of diabetes at any age is to be thirsty all the time and drink a lot and to pee a lot.
Right.
And it just happens that in a newborn that is those are both reassuring things and are nearly impossible to distinguish drinking and peeing too much from the normal amount because they're drinking and peeing a lot.
Right.
And so almost invariably, and I'm sure many people listening here who have gone through this would know better than any of us that that almost invariably they end up going many weeks or months until someone figures out what they have. If they are lucky, they might have incidentally blood sugar checked, or they might have ended up in the NICU because they were a little small or whatever and had a blood sugar checked. But for the most part, the families, if you ask them, will say that they told a nurse or a pediatrician or medical provider, in many cases several times, about their concerns before anyone checked a blood sugar. And as Graham Bell likes to say, the mom always knows best. And, you know, these moms knew that there was something wrong, and hopefully some of the dads too. But it was really hard for the clinicians to diagnose. And I'm not saying all this to blame clinicians, because it is really hard to tell. But on the one hand, we've been trying to raise awareness and help to educate people out there that these forms of diabetes, even that they exist, because unfortunately, it's not very well known amongst medical providers that neonatal diabetes can even occur.
Right.
And so while we're trying to, you know, improve from that side of things, really the best way is to try to figure out a way to diagnose these babies before they get sick. And that's actually the whole point of the newborn screening programs that exist in all 50 states in the United States and in many countries around the world, especially the more industrialized, developed countries that have more resources. And the main criteria for the types of disorders or diseases you would consider screening for as part of that testing are, number one, if it is very difficult to diagnose. And number two, if you have a treatment for it, then that makes it an even higher priority, especially if by getting that treatment, you can help to prevent a lot of the poor outcome and the bad stuff that can happen, like developing diabetic ketoacidosis and ending up in the ICU, etc.
Right.
And so our disorder with diabetes clearly fits that, because it's really hard to diagnose. And there's definitely a treatment, whether it's sulfonylurea or insulin. Insulin will work in all babies and will help to bring those blood sugars down and keep them healthy and safe. And then will help us to identify cases who are appropriate to get genetic testing done and help them to get that diagnosis even sooner, so that we can help them to get the right treatment there sooner as well, whether it's sulfonylurea or not. As many people will hopefully remember, if they've ever been with a baby who was born recently, the way it happens is there's a heel stick that's done on babies who are supposed to be at least 24 hours old, up to about 3 days old, and is done sometime before they go home. And currently there are many, many different disorders that are screened for through that testing. Some of the more well-known things, at least to us endocrinologists, include like congenital hypothyroidism, which is very important for brain development, and congenital adrenal hyperplasia, and then really rare kinds of things. And I like to mention something called maple syrup urine disease. There are really, really rare disorders out there. And in fact, many, many of those disorders that are currently screened for on newborn screening are actually less common than neonatal diabetes, even though it's 1 in 100,000 cases, and that sounds really, really rare. There are other types of disorders that are even more rare than that. So it kind of checks a lot of the boxes and fits a lot of the reasons why you would consider doing newborn screening. And so the only criteria that we don't have to be a good choice for screening is having the right test that will work well to not only identify babies who have diabetes or high blood sugar levels, but to do so in a way that hopefully won't overcall other babies who don't actually have diabetes. So you don't, a good screening test will hopefully not miss very many babies who actually have the condition, but preferably not screen positive or have false positives for babies who don't have diabetes, because that will cause a lot of stress and anxiety and needing to get rechecked and all that for babies who don't have diabetes. But because it's pretty easy to get your blood sugar checked, there is some argument that even if you have a few false positives, that it would be appropriate to set that cutoff in a way that we would hopefully not miss very many babies. And so the encouraging thing is that what we've been doing over the past couple of years is we've been working on developing exactly such an assay that can detect blood sugars in babies. And we've been doing this in collaboration with the team at the University of Madison, Wisconsin, and the state newborn screening lab there, and in particular, Dr. Patrice Held and her team, who have been really wonderful partnering with us on this. And our preliminary data suggests that, for example, it is very, very rare for any baby to have a blood sugar above 120 in the first few days of life. And so 120 could end up being a good cutoff. But we need to do much more testing still to see if perhaps very, very few babies even get above 100, let's say. And so that might be a good cutoff to try to make sure we're not missing babies. And we do, on the other hand, have some data from babies who had blood sugars checked very early on when they had known forms of diabetes. For example, some people have grown up with those mutations and have had babies themselves. And in most of those cases, they have a 50% chance of passing it on. And knowing that, in many cases, these babies were followed very closely after they were born, and we were able to see their development of high blood sugars, which looks like does occur, particularly after about 24 hours of age. Their blood sugars really seem to rise above normal, and kind of progressively so in the first few days. And so we think, for example, patients with the K16J11 and ABCC8 or the KATB channel mutations that are most common, we think those would be very likely to be picked up, as well as the ones with the transient 6q24 related, that those seem to have really high blood sugars very early on. And so we think there would likely be a reasonable cutoff where we would detect their hyperglycemia as part of the newborn screening. However, there are likely to be some forms that may not be picked up very well. For example, the insulin gene mutations, which we know that they kind of experience a somewhat longer term progressive loss of their beta cell function because of cell death that occurs over time. And so not all of those babies would be picked up, but we think. But if, even half of the babies, or even, 30% or whatever number of babies were picked up and we could prevent their bad outcome, that would be awesome. We will have to do a cost effectiveness analysis to see how much does it cost to implement this new testing as part of the procedures, and how many babies will we be able to detect and prevent a poor outcome, and is it kind of worth it in a sense? I mean, some of us would say, of course, it's worth, whatever it takes, even if it's very rare. And I think we have a pretty good chance because, like I said, many of the other tests already included are very, very rare as well. And our society in most of the states has kind of agreed that it's worth spending a certain amount of money and resource and time in order to make sure these babies do okay. And the key was in partnering with Dr. Held and her team and considering a test that could be implemented into the current workflow of testing as it's done right now in newborn screening labs, which happens to use a technology called mass spectrometry. And it's basically taking just a tiny bit of the blood off of these blood spot cards that are collected. And then you kind of suck out that little bit of blood and then send it through this machine, and you see these peaks, and you're able to tell which one is glucose and how much it is from that. And so we're hopeful that this will be able to identify babies with diabetes. Now, the part that I haven't yet mentioned, if I can keep going on a little bit longer, is that we need everybody's help out there who have had babies with diabetes, because although we've been looking so far at just kind of random babies who don't have diabetes and what their normal blood sugars are, and we think babies with diabetes have blood sugars that are high enough that we would detect it, we really need to prove that. And the best way to prove that is to find the actual blood spot cards of actual babies who were born and then later were diagnosed with diabetes. So even if someone, let's say, was diagnosed at 3 months or 4 months or 6 months of age, we want to go back to their blood spot card that was collected when they were 1 day old or 2 days old and see, is it possible that we would have been able to detect even that slightly elevated blood sugar early on, and then, theoretically could have prevented, whatever they experienced after that. And so right now, the unfortunate thing is that it's a bit of a logistical nightmare to do this research because all of the 50 states have a completely separate process that is dictated by the states on their own. There's no like federal specific guidelines dictating what states have to do. But it turns out that many states such as California, Michigan, New York actually keep these blood spot cards for years after they're collected, specifically for the purpose of people being able to do research and potentially develop new tests and that kind of thing. And so some people out there might be saying, well, my kid was diagnosed 10 years ago, or even individuals who are older now are 20 saying, well, would my card still be good, 20 years later? Right. It actually might still be available, at least in some of these states. There are other states, for example, Illinois, unfortunately, basically throws away the cards after a few months. And so we really can't do much in Illinois. But in these other states, we are really hoping to get people signed on. And all it takes from the individuals is just basically to sign a new consent form for us. And we're already in touch with the states and can process everything and say that you gave us permission to go back and get a piece of that blood spot card so that we can test it out.
Wow. That's great. So just to reiterate what Dr. Greeley said, so if you're interested in sharing your child's the blood spot card, you can just email our team at monogenicdiabetes@uchicago.edu and express interest in the newborn screening project. So we can now move on to some questions that people sent in. Our first one is related to COVID-19. So we, are learning every day more about COVID-19 and know that people with pre-existing health conditions should be monitored more closely. So the first question is there an increased risk for neonatal diabetes patients if getting COVID-19 compared to normal? And I'm guessing normal is someone with diabetes or someone normal that doesn't have any diabetes at all.
Right. Well, this is the same kind of question we're taking from patients in our clinic with other kinds of diabetes. And the truth is we don't have any actual data to say what exactly the risk might be of these different gene causes. But I think it's fair to extrapolate that for most of the patients with these forms of neonatal diabetes, the diabetes is the biggest thing affecting their overall health and their immune function in particular. And while people might have heard in the press about people with diabetes having a higher risk of being sick when they get COVID-19, This has essentially almost invariably been amongst older people. So having an older age is by far a much bigger risk factor worth considering than the diabetes.
Okay.
And so, for example, people who are 60 years or older are at especially high risk, but even 40s, 50s, if they have diabetes, if they have obesity, um, those are some of the big factors that are associated with risk of getting sick if they catch COVID-19. There isn't, by the way, any evidence, even with those patients, suggesting that, or at least not that I know of, that they're more susceptible to getting the virus necessarily. But if they do, they can get sick. Now, fortunately, it does not seem to be the case that younger people with diabetes are at higher risk of getting sick. It looks like the being young is a much more important factor, and that seems to really protect people from getting sick when they have COVID-19. And so, University of Chicago, we've been very much in close touch and part of a collaborative international group, very specifically trying to look at this question about people with diabetes and the relationship with COVID-19. And the good news really is that younger people, pediatric patients, have not really been getting sick with COVID-19. And so, does that mean you should not be concerned at all? Of course not. I think all of us need to be concerned and careful and trying to do everything we can to prevent ourselves from being exposed to the virus. And so all of us should be doing the social distancing and wearing masks and washing hands and not touching our face and all of those things. But because of the diabetes shouldn't make you do any of that necessarily more or less than anyone else. Now, I'll just mention that there are some rarer forms of neonatal diabetes, in particular ones that affect the immune system, where they could theoretically be at greater risk of trouble. But those cases are very rare. If anyone out there thinks they have one of those cases and they want to talk about it, I'd be happy to. But I think still for everybody, it's taking precautions. And so one of the big questions that has come is, should I send my kid to school? And my answer has generally been, well, if it's currently in your area, there's a high enough prevalence of people testing positive out there that the virus is really spreading and the curve is still going up. And, there is uncertainty about going back to school, then, just like everybody else, it's probably best to hold back. Whereas if you feel that in your community and your government is being careful and appropriate and the testing is low and it seems like a lower risk, you could consider sending your kid back, potentially even if they have diabetes. But there's a lot of difference of opinion here, and I think the nice thing is, from what I've been hearing, is that most governments and school districts are being very understanding, and if any parent is uncomfortable and chooses to want to keep their kid at home, at least in our area, there hasn't been any penalty for that. They're accommodating that for anyone who chooses to do so.
Okay, great. Thank you. So now we're going to switch gears a little bit and go into more clinical care and more medication-specific questions. Of course, I want to preface this by saying these questions and anything Dr. Greeley says should be discussed with your healthcare provider. And of course, he'd be happy to schedule a telehealth medicine with you to talk about this in more detail. So feel free to answer these questions as broadly as you would like, Dr. Greeley. So the first one is, are there any new medications out to treat neurological impairments as well as diabetes?
Right. This has been something of great interest to us and especially to the families who are struggling with the most common form of neonatal diabetes that we talked about, the casein J11 and ABCC8 mutations, the KATB channel diabetes. As I mentioned, because of the brain expression of those channels, that those babies and those individuals as they get older often do have different kinds of neurodevelopmental struggles. And while some of our research has suggested that treatment at an early age with the sulfonylurea drugs does seem to at least help to some extent, it clearly does not prevent that kind of outcome completely. And so the question is there any kind of drug that could more effectively help with the neurological difficulties? Um, and part of the reason that we think that's at least theoretically possible is that there's data showing that the sulfonylurea medications do not seem to get into the brain and stay there very well. I think we have pretty good evidence that they are able to get in there enough to make at least some difference. But what we don't know is if we could find a medication that could get in and stay there better, is there a chance that people could do better with these neurological difficulties? There isn't, the answer to the question is that there is not any new drug that has been identified. There have been at least one other anti-epileptic drug that has been considered and has been tried by a few doctors of a few patients. The problem, the challenges being several in that that particular medication, there are other side effects and other concerns about that kind of treatment. And so in order to be able to be more sure, it would be important to try to do a big clinical trial.
Mhm.
And that has its own challenges because there are so few patients. That's a difficulty in itself. But one of the things that we've been working on is developing a cell system that many of our patients who have visited Chicago or participated in our family meetings have donated samples from which we can take the cells from their blood and actually grow them into little collections of neurons that are not really exactly like brain tissue, but have enough similarities that if we can show in the laboratory that those cells seem to do better when they're exposed to different kinds of drug treatments, then that might give us more of a clue about drug candidates that might be more effective. And so all I can say is that the work is ongoing. I've more recently been trying to send out feelers to other groups and kind of opportunities where similar kinds of efforts are going on for other kinds of rare diseases to try to leverage that kind of interest. And it's certainly something we think about a lot, and because we know we would like to help people out there as much as we can.
Mm-hmm. Great. So you were discussing earlier about oral sulfonylurea being really effective with some of these forms of neonatal diabetes. So one person asks about glyburide. So this participant has normal blood sugar values but dry skin. Is that a normal side effect that you see with taking glyburide?
I can't say that that's one that I've heard before.
Okay.
The most common side effects have been a little bit of stomach upset, which usually tends to occur early on, like within the first few weeks of treatment or even days, and then tends not to be as much trouble. Although in rare individuals, it seems like that can cause some trouble even later on and may be somewhat dose dependent. But the good news is that there really haven't been major concerning side effects of the treatment, even when these patients are taking like many times more of the drug than other patients with, for example, type 2 diabetes, where a very large, like 250-pound individual with type 2 diabetes might take a single pill that's 1.25 milligrams, whereas many of our patients out there, uh, even if they only weigh, 100 pounds or 150 pounds, might be taking 4 or 6 or 8 pills that are 5 milligram pills, and
Right.
potentially even multiple times a day.
Mm.
And so you might, and so we've been very intentionally trying to collect as much data as we can over the long term about whether there are any um, side effects that we wouldn't anticipate or wouldn't know about, because those are have not been doses that have been tested by the FDA. And the good news is that so far nothing has really come out, and this is now the experience collectively with Exeter and other international groups who published a paper from the European experience a couple years ago, that over 10 years and hundreds of individuals, there really hasn't been any other major concern. One of the other issues that does come up as a question is the risk of low blood sugars, which overall is very clearly a lower risk than people who are taking insulin. Um, and for the most part, we have not really seen severe hypoglycemia, except in maybe very, very rare cases. And that doesn't even seem to be dose dependent exactly. But we've heard of tooth discoloration, actually. So yellowing of teeth, which probably people can see. My teeth are a little bit yellow because I drink a lot of coffee. That's like the ghost coffee here. Um, and but dry skin, I haven't heard of.
Okay.
That's the
Great.
short answer to that question.
Love it. Thank you. I do have a question here about dosage. So, someone asks, I find that with my kids, the larger the dose, the more stable their sugars. Any idea why?
Um, I would need to know more details about that specific situation. So, for example, how much the person weighs and how many pills they're taking. So, like what dose they're on. Uh, what we have seen and what the Exeter group has seen is that um, depending on how old you are, you will need more or less of the medication. So lately, we've been starting the medication on babies who fortunately are being tested at an earlier age than they were when all of this was new. So way back when this was new, someone may have had the diabetes for 10 years or 20 years and then finally got the genetic testing and tried the treatment. Whereas now it's been more in babies, and we found that the babies tend to respond much quicker. Whereas if someone starts when they're 15 or 20 years old, it might take a lot more of the medication per weight too, um, in order to be effective, which kind of makes sense if you think that the beta cells in the pancreas that make insulin have for 10 years or more not really been doing anything and may have kind of died out. It's kind of amazing they can wake up again, but it makes sense that they need more. Um, but what we have found is that once you get up to a dose that works, going to an even higher dose does not seem to necessarily make it better or worse. And so the individual asking the question, I wonder if they were maybe at a relatively lower dose that wasn't maybe quite the ideal dose that is really working, but once they got up to that better dose, then maybe it's really working appropriately. We've had experiences where doctors out there who might not have had any other cases, and it's just the first case that they're taking care of. Once they get started on a certain dose and they're following a patient, they might hear the patient telling them that, you know, we've occasionally had a few low blood sugars, and then there might be a temptation to decrease the dose. And unfortunately, in some cases, they've decreased the dose so far that it no longer works very effectively, and then their blood sugars get a lot higher. Right. So there are some, you know, pretty particular issues, and it can be a little complicated. And so if anyone is having those kind of questions, those kind of struggles or concerns, I definitely encourage you to reach out to our team. So you can send the email to the monogenic diabetes at UChicago.edu and just ask your question to our group there. And then depending on your insurance situation or your situation with your treating team, if it's appropriate, I'd be very happy to set up one of these clinical official Zoom visits so that we could talk about all that. We can answer your question and talk to you anyway without the official clinical visit, but sometimes the official clinical visit can be helpful, especially if there are issues with your team locally in helping them to better understand if they get something in me, kind of the official, like in writing kind of assessment. That can sometimes be helpful. And what we've all been kind of saying about the COVID-19 having a silver lining, in a sense, is that being able to do these official clinical visits remotely is a totally new thing that, you know, we were not able to do before March of this year. And this special exact moment in time right now happens to be the best time to try to do it, particularly across state lines. Because right now there's much more understanding from insurance companies and everybody about letting that happen, whereas it may not last that it will be this permissive to be able to do it, although I think there will be ways to do it going forward that'll be much better than we had before. So in summary, if anyone is interested, we can investigate, see if it will be covered by insurance, but even if it's not, we'll find a way for sure to talk with you, answer your question, to help you out, or talk to your doctors as well.
Perfect.
But please don't change anything until you talk to your own doctors.
Yes, perfect. I did want to get to two more questions from two different people. Just keeping in mind we have 2 minutes left, so as concise as possible, if we can do it, we're going to ask about GATA6. So the first part of the question is a participant, their daughter has a GATA6 mutation, would like to know if small kidneys is a feature. And then the other part of that question is how effective pancreatic transplants are in patients with GATA6. So small kidneys and the pancreatic transplant. Two questions.
Yeah, so that's a great question. Particularly the pancreatic transplant question is interesting. To remind everyone out there, GATA6 mutations are pretty rare, but they happen to be the most common cause of being born without a pancreas, which is very, very, very rare. And I will say also that some people with GATA6 mutations will have part of the pancreas, but it usually is a very small part that doesn't work very well. And they often also have cardiac defects. But so many people with diabetes might think of their pancreas as only making insulin. And the truth is that the pancreas is a fairly big organ where only little bits of it are cells that make insulin. And the rest of it is actually really, really important for digestion of your food. And so these individuals are not only dealing with diabetes and high blood sugars, they also have to address this very, somewhat difficult and challenging situation of taking the enzymes that their body cannot produce. They have to take these enzymes with every time they eat in order to help their intestines break down their food, to have normal digestion and absorption and everything. And there's a lot of uncertainty about exactly how much they take for all of their different kinds of food, and that can affect how their blood sugars go up. And so these individuals, I really feel for them because their diabetes is very, very challenging to manage. Lots of ups and downs and very, what we would call brittle diabetes. So while there would be a consideration of pancreatic transplant in these patients, because, if they don't have a pancreas, it sounds good to get a pancreas transplant. The problem with the pancreas transplant is that currently, if you just get a pancreas donated by some unfortunate individual who dies, you would have to take very powerful immunosuppressive drugs for the rest of your life in order to make sure your body doesn't reject that pancreas.
Mm-hmm.
And so that kind of medical treatment is, first of all, very, very difficult to keep up with because there are a lot of pills involved. And there's actually no guarantee that it won't be rejected anyway.
Mm-hmm.
But it has very powerful effects too on your immune system and makes it so you're living in a somewhat immunocompromised state,
Mm-hmm.
which, right now with COVID and whatnot might not be such a great thing. Um, Although actually those patients, by the way, seem to be doing okay with COVID. But the point being that it's a really, really big decision to get a transplant and go on that kind of regimen. So I would not automatically recommend that for anyone.
Mm-hmm.
But if they've reached a point where their diabetes and everything else is so difficult, there are centers that have been doing islet transplants or potentially pancreas transplants. But you'd really want to be like really weighing all of the considerations. I think what is becoming more and more a possibility, it almost sounds like science fiction, is that there are a lot of groups learning how to try to grow new organs essentially from people's cells. And theoretically now we could try to change the mutation that they have in the GATA6 by taking their cells, fixing the mutation, and then growing new cells. And there's going to be quite a while, I think, before we do all of the steps of studies and everything that are necessary to make that really happen. But I think it is feasible.
Mm-hmm.
And the other thing I would mention is that with the pump and continuous glucose monitoring technology, insulin pumps, I mean, that it does make managing diabetes much better than it used to be. And there's a particular kind of pump that we hope will be coming out in the next couple of years that will have not only insulin, but will also have glucagon, which is also what's missing in those patients. And so that what we call bihormonal insulin pump might be an especially good choice for those patients. So pancreas transplant, worth maybe thinking about, but hopefully there are going to be better options coming up.
Mm-hmm.
As far as the small kidneys, I can't say that I've heard of other patients with that. I would be curious to know more if that was something that was seen early on or is much, much later. And if it's much, much later, how has their other signs of kidney function or dysfunction been? And is it necessarily related to the GATA6 or the diabetes?
Mm-hmm.
Because we haven't really seen that as a feature.
Okay. Perfect. Well, thank you so much, Dr. Greeley. That is all the time that we have. I think we learned so much about neonatal diabetes. If we did not get to your questions this evening, like we mentioned, you can send any of your questions to monogenicdiabetes@uchicago.edu. We'd be happy to answer them there. And then also
I was just going to say, did we post the link or the email address if they're interested in scheduling a visit or
Yep.
anything like that too. They can do that.
Yep, exactly. That should
Okay,
be
great.
right below us or somewhere around here. But
Okay,
yeah,
great.
they can do that as well. So yes, again, thank you so much for joining us. We will be back next month with another webinar sharing more about monogenic diabetes. So thank you so much, Dr. Greeley, for joining us.
It was great to spend this time. I wish I could see everybody's faces. I'm sure I know a lot of you, and we hope to do more of these things as a way of connecting with everyone. So really, thank you everybody for joining us and participating in our studies and everything. We really appreciate it, and we're there for you if you need anything.
Absolutely.
Take care.